It checks down schools. Or any minute. Yeah. Bas. And it will come when it comes. Yeah. I'll just pick it. Okay, I'll tell you.
Good evening, everyone.
Hi, sir. Good evening.
Good evening, Sushant. You can hear us? You can hear me?
Yes, yes.
Good evening, sir. Lakshmi here.
Good evening. Good evening, everyone. Good evening, Dr. Soneji, ma'am.
Good evening.
While we wait for the session to start for the next 2-3 minutes, I hope everyone has voted for the IAP elections.
Yes.
Yes, sir.
Anybody has any difficulty, please tell us in case there's any issue about the link or anything.
That was quite smooth. They have
Soneji,
sent the mails pretty well. It's quite self-explanatory also.
The mails and the messages
yeah.
also, text messages.
Yeah, both SMS also were there.
Madam, you also voted, Soneji, ma'am?
Not yet. Tomorrow, I think. I just came back from outside Bombay.
Okay.
Yeah, tomorrow, definitely.
Yeah. I think I'll request everyone that those who have not voted, it takes hardly 2 minutes. It's a very,
Yes, yes.
very smooth process.
Yeah.
And you just click, and it's over.
Yes.
So you can literally do it right now also. And, please do. Please, everyone, please vote. Yeah.
Yeah. So latest Jawan has said use your vote to claim the rights.
Yes, yes.
Yeah, so everybody should go ahead, I guess, with the heat sequence going on.
No, it really takes hardly 2 minutes.
Hardly 2 minutes.
Hardly
It's very smooth. It's really smooth.
Okay.
And they have got the helpline number also in just case if you can't just vote or there is any difficulty. So it will be quite smooth for that.
By chance, if anybody hasn't got the SMS or email or you can't find it, there is another link where you can generate your own personalized link. So you can contact us and we can help you with that.
Yes.
ખબર નહીં આ વિડીયો સ્ટોપ થશે તો બસ લે થઈ ગયો ને
બસ હા
સુશાંત માને actually
Okay, so it's 9:30, so I think we'll start.
Yeah.
So, good evening, friends, and welcome to this online session, which we have named as our Webflix series. So, we've arranged a series of 4 programs in this week online. And, what we observe is in all conferences, we have experts giving talks, and then the audience usually doesn't get time to ask their doubts or questions. So, we have tried to plan this a little differently, as in neither the speaker nor the moderator has a set PPT to finish. We will just set the ball rolling with the moderator asking some relevant question, and then every one of you related to that topic or to any other aspect, if you have a question, please put it in the chat box. Please keep yourself muted throughout so that there is no disturbance, and the moderators will keep picking up the relevant important questions that are important for everybody, and Sushant will answer. I think all of you know Dr. Sushant Mane extremely well. He is an undisputed authority in tuberculosis now, and who better to learn from than him? And obviously, he has the latest changes also up to date with him, and therefore that's the best person to learn from any doubts in tuberculosis. So I think with those opening words, we'll just start the session. So over to Dr. Arpita, who's moderating today. Arpita.
Yeah, thanks, sir. Good evening, everyone. As we know, 22% of the global burden of pediatric TB each year lies in India. We have more amount of extrapulmonary tuberculosis than in adults as per compared to the kids in India. But still, there is a huge detection gap under 5 years of age to detect and report the tuberculosis cases. Just to bridge this gap and just to update ourselves, we have our expert today, as Sir said, Dr. Sushant Mane. So who will stump all our queries since the World Cup mania is going on. Please put your all googlies in the chat box and so we'll stump them all so we can all together win over the tuberculosis. So just to kickstart the session, sir, what will be the features or manifestations when the patient comes to us? Then we should start thinking in terms of tuberculosis.
So as you know, all of us know here, many of the senior persons are here. We have been learning since our undergraduate days. Anything which comes as a clinical feature, we can suspect TB. Okay, and that is because there is no organ in the body which is spared by tuberculosis, right from the pulmonary. Yes, lungs are the main, but then you have the intestines, you have heart, you have kidneys, you have everything. So when we talk about symptoms, so when we talk about the cardinal symptoms, we have fever. Okay, so when we talk about pulmonary, as pulmonary is the commonest, fever, cough, and weight loss, or not able to gain weight. So any of these symptoms going on for a period more than 2 weeks, we should keep tuberculosis as one of the DDs or differential diagnosis. The fever has to be at least documented once by the parent over a period of 2 weeks, at least once or twice. It has to be documented. Just feeling that the child is warm or febrile may mislead us. As far as cough is concerned, it has to be a persistent cough or a worsening cough. Okay, because we have to characterize cough. Now we have obstructive airway diseases where the cough would be a recurrent variety of cough. Like it will be there for a few days, then it will become child will be completely asymptomatic, and again it will pop up. Such kind of cough generally do not point towards a chronic disease like TB. And the last is weight issues. So there are two concepts to it: either the child is losing weight more than 5% weight loss is documented over the past 3 months, or the child is not gaining weight adequately as the child should gain. But before jumping to the weight thing, I mean not gaining or losing weight, we should take the diet history of the child. Okay, the child should be eating proper diet. In spite of that, if the weight child is not showing good results on the growth chart, we consider that the child is failing to thrive. Anything going on for more than 2 weeks, we consider TB. And when we talk about extra pulmonary, so from head to toe, okay, we have soft CNS signs like persistent headache, vomiting, like a insidious or a slow onset meningitis, chronic back pain, because in osteoarticular TB, pot spine is very common. Any swellings coming up anywhere into the body, especially cervical nodes, inguinal nodes, axillary nodes, which are painless but persisting. So basically, any non-specific symptoms which are there, which are there for more than 2 weeks, TB becomes one of the DDs.
That's great, sir. So anything persistent cough for more than 14 days, documented weight loss, documented fever, and extrapulmonary signs, as you suggested, we should point off the tuberculosis. So what should be the test protocols? Like once we have assumed this child can be having the tuberculosis, what are the investigations we should ask for? And what will be the role in current situation of like Mantoux test, TB Gold, TB ELISA? There's so much plethora. How we should systematically go for it? Just and CTB test, which is newly coming up. Please highlight us for the same. So,
Okay, so let us divide this into a few parts. When we talk about
yeah.
investigating a child for active TB, so when we talk about tuberculosis, it has two concepts. One is an active TB, or where it's the active TB disease, and something known as TBI or TB infection. Now, what is the difference between these two is TB infection means the person is exposed to tuberculosis antigens. Okay, the disease was there due to some factor, most probably a good immunity and good nutritional status of the child. The disease manifestations didn't come up, and the infection has remained dormant into the body. So the person has been exposed, infection is there, but the person is or child is not manifesting. That is TBI or TB infection. And when we say TB disease, that is what we spoke about just a few minutes back. All the signs and symptoms or clinical features, when they come up, we say the child has active disease. Now when we talk about diagnosing active TB, okay, then there are certain set of tests what are available now. So now since 2017 we have moved upfront to the molecular tests. So everybody of us has heard about Gene Expert, which is the CBNAT, cartridge based nucleic acid amplification test, which is a completely automated test. So that is the first test. So whenever we are labeling any case as a presumptive case of TB, depending upon the signs and symptoms, the first test on any sample which we do is a CBNAT. Okay, now if you're talking about a pulmonary TB, obviously we are sending a sputum. If the child is old enough, 6 or 7 years and above, he is able to cough out sputum, we give a sputum sample. Or a younger child, when the child is not able to cough out sputum, we are getting a gastric lavage done into the patient or a gastric aspirate done. As far as extrapulmonary TB is concerned, anywhere. So if it is we're talking about a CNS, we send a CSF sample. If you're talking about a lymph node, we send a lymph node biopsy. Or if there is pus sitting in the lymph node, we can do aspiration of pus and send the pus for CBNAT. So the first test which is done is CBNAT. Then CBNAT, what does it do is it is a molecular test. It picks up the mycobacterial DNA. Okay, so the MTB complex are a specific DNA sequence it picks up. So, and the advantage of that test is it will not only tell whether the sample is containing MTB, but it will also give us upfront rifampicin resistance. So this is very important. The change which has occurred since 2017, we are looking at upfront rifampicin resistance in all the patients. That is because the numbers of DRTB are going up, not only globally but also in India, and that is why we want to have a confirmed diagnosis right at the beginning, so that appropriate therapy can be given to the patient. So if it is rifampicin sensitive, it directly goes to a sensitive treatment. If it is a rifampicin resistant, then the protocol moves ahead. So that is the information what CBNAT gives. The next thing is some molecular test, which is something known as an LPA or line probe assay. Now, what is the advantage of line probe assay over a CBNAT is like like CBNAT, it also gives us whether the sample has MTB or not. And in addition to rifampicin resistance, it also gives additional information about resistance to isoniazid and the other second line drugs like your quinolones and injectables. That is your levoflox, moxiflox. Those are the fluoroquinolones and injectables. That is amikacin, capromycin, kanamycin. So that is again one step ahead. We can get the complete resistance pattern, and then we know that DRTB is divided as MDR, pre-XDR, and XDR. So depending upon the LPA results, we can classify and start appropriate treatment. Now there is one hinge when we talk about LPAs is now LPA test can be done in a pulmonary TB sample only if the smear is positive. So when the sample goes to the lab, okay, the sample is the two samples are collected. One sample goes for CB-NAT. At the same time, some amount of sample is mounted on a smear, the traditional Zeal-Nielsen smear, which we have learnt in our MBBS days. And the smear is also looked under the microscope. If the smear comes positive, an LPA is run on that sample. So the first line LPA will give you resistance pattern to rifampicin isoniazid. Second line LPA will give pattern to the quinolones and injectables. What happens if smear is not positive in a pulmonary TB case, or in extrapulmonary TB, like for example a lymph node aspirate or a pus aspirate smear is not done? In all such cases, a culture is mounted, and once the culture turns out to be positive, if the culture turns out to be positive, then on the culture isolate we do the LPA test to get the resistance pattern. So these are the two types or the two stages where LPA can be done. So if it is done directly on a smear sample, it is known as a direct LPA. If it is done on a culture growth, it is known as an indirect LPA.
Right, sir.
Yeah.
So we have got a few interesting questions about the already diagnosed cases of TB and how to monitor the response. One of
Okay.
the question is 14-year of child, sorry, 11-year child. He has come with the diagnosed case of abdominal tuberculosis. First line AKT has been given for 6 months. Repeat USG is done. There is improvement but not resolved completely. There is a weight gain of 10 kg. How long should we continue the AKT?
So if we talk about abdominal TB, okay, now when we amongst the tuberculosis, all the extrapulmonary tuberculosis, the most I would say googly is abdominal TB, because the establishing of diagnosis only is so difficult. As we said, now we are we are stressing that each and every case should be microbiologically diagnosed. And if you see abdominal TB, most of the abdominal TBs are diagnosed clinically. Nobody takes an effort to actually do a lymph node biopsy from the abdomen. And because nodal TB, abdominal nodal TB is the most common variety, and then you have intestinal, ileocecal, and all those things. So in most, at least 60 to 70% of the times, abdominal TB is started on treatment empirically, that is on clinical basis and USG findings. Having said that, we have to all see first. So what is happening is, what cases we are seeing after 3 months or 4 months referred to us as, lymph nodes are same on USG. When we go back and take the history, clinical history, the examination findings, and see the relevant reports, we come to the conclusion that this was not TB at all. So the commonest errors in abdominal TB for starting is seeing lymph nodes into the abdomen. Okay. And why do we see lymph nodes? Because for each and every abdominal complaint, a USG is ordered. So again, let us go back to our clinical practice. If a pediatric patient comes to us, the mother is telling, "बच्चे के पेट में दर्द है." Let us, go into the details and characterize these symptoms. Now, पेट में दर्द can be a very vague symptom. Okay. I mean, 6 to 7 out of 10 pediatric patients who come to us with abdominal pain are functional. Most of the times they don't have anything, or it could be some other reason like a worm infestation. So first and foremost, what we must do is characterize the symptoms, how significant it is, and it is for any pediatric complaint. Is it affecting the daily routine of the child? Has the diet of the child getting affected? Everything. Has he missed school because of that abdominal pain? Most of the time the answer is no. So then why did we order a USG in the first place? Okay, so that mistake happens is for every pain, मतलब on an average what we have seen is 3 दिन से ज़्यादा abdominal pain है, a USG is ordered. Okay, that is the first thing what we need to introspect whether we should order a test or not. Second, whenever a USG is ordered, okay, whatever the report we get from USG, most of the times the report says some size nodes 0.5 by 1 centimeter or 1 to 1.5 centimeter and correlate clinically. Okay, most of the reports don't give us actual characteristic of the nodes. So if we really suspect that something is going wrong in the abdomen, the patient has organic symptoms, it is not functional, and we want to do a USG, and we get such type of reports, it is always better to go back to the radiologist and ask, look, you have reported the nodes, but you have only told us about the size. Okay, we want to know whether the nodes are matted or not. What is the nodal architecture, whether the corticomedullary ratio is maintained or it is lost, whether there is necrosis seen within the nodes. Okay, so all these things are very important. So if a reporting radiologist should mention all these things. Again, every necrosis in a node may not be TB. Okay, a bad gastrointestinal infection, for example, if a child lands up with a bad adenovirus infection, enteric fever infection, he is going to get necrotic nodes. So again, we go back to the same thing, characterize the clinical symptoms, then order the investigations, and once we order the investigations, correlate clinically whether it is matching. Okay, now in this case, suppose if we consider that this child was diagnosed properly, started on therapy for 6 months, okay, and now the question is USG is showing improvement but not resolved. Okay, so what do we mean by that? What do we mean by improvement? Okay, so nodes decreasing in size. Suppose it was a 2 centimeter node, now it is 0.5 centimeter, still present. It is considered as a response because the size has come down. Sometimes the size may change marginally. A 2 centimeter node would become just 1.5 centimeter, but the radiologist would report calcification seen within the node. So if calcification is seen, again it is a sign of healing. Okay, so all these things need to be reported. And the next thing is the patient has gained 10 kg weight. What else do we want? Okay, so resolution is there in USG. Patient has gained weight. Clinically, the patient is okay. 6 months is the only therapy what we give for HPV. So we can start the treatment with the child.
So with the same context, somebody has asked that mesenteric lymphadenopathy is difficult to diagnose. Can a stool sample prove TB with some test?
So we have stool genome. Okay. Now WHO has approved CBNAT on stool. So they say that CBNAT Ultra is a better test to be done as compared to CBNAT because the sensitivity is higher. But the concept of that is it is not the abdominal TB which comes in stools, but the pulmonary sample which this child gulps down. Okay, the child is not able to throw out sputum. Those AFB can be picked up in the stool sample of the patient. So for pulmonary TB diagnosis, yes, stool gene expert ultra is recommended. Abdomen TB per se, if you see the organisms, they are there within the uh, lymph nodes, sitting inside the lymph nodes. Unless and until the lymph node has burst into the intestine and there is a discharge caseous necrosis, which most of the times won't happen. And if that happens, the child would be a sick child. Okay, it would be an acute abdomen kind of a child. You're not going to get that sample in the stool. So stool gene expert, yes, for the diagnosis of pulmonary TB.
So in context with another extrapulmonary tuberculosis, one of the question is 14-year-old child with pot spine treated with first line of drugs, treated for a year, significant improvement but still not resolved completely. So maintenance therapy continued for 6 months. Almost complete resolution, but a small collection is still remaining. Is it safe to stop AKT?
So again, the same concept. Okay, if there is significant resolution, and suppose initially the most of the time spot spine has paravertebral collections. So initially, if the collection was 10 to 15 ml or 20 ml, and now it is 2 ml, just leave it. Okay, because pus may take time to dissolve. Even in an empyema, tuberculosis or sometimes bacterial empyema, you give treatment for 2 weeks and 3 weeks, everything is gone. But initially, the empyema was 25, 30 ml. Now the fluid is 10 ml or 5 ml. We leave it. Okay, because pus takes time to
રાતનું બંધ કરે મારે દવા ઓર્ડર કરવાની હતી.
Yeah.
the treatment what we give for pot spine. So if the patient has
Now you
taken,
can't have both. આનું ને આમાં બી.
Hello, sir, can you mute yourself, please? Hello.
yeah, it's muted. I
Yeah,
think.
sorry, there was some this thing. So another one like CNS tuberculosis, but associated with the HIV infection. There was an 11-year-old child, case of tuberculous meningitis. He was started on, sorry, this is a different question. Sorry. I'll just go through the first question. HIV and CNS tuberculosis, how long to treat? There's a lot of variation. So there's some clarity on the protocol for HIV with CNS tuberculosis, how to manage response and how to repeat the test and diagnose.
So whether the patient is HIV positive or negative, the duration of treatment remains same. So if it is a drug sensitive tuberculosis, it is 6 months of treatment, except for CNS TB and pot spine, where we give treatment for 1 year, whether it is HIV positive or HIV negative. So even if a HIV positive child has a drug sensitive CNS TB, the treatment would be for 1 year only, and we don't extend. Monitoring, how to monitor? Yes, we monitor clinically. Okay, and then suppose it is so monitoring of not only an HIV positive patient but even an HIV negative patient. What we do is, if it was a pulmonary TB and the first sample was positive, microbiologically confirmed TB, at 2 months and at the end of 6 months, we repeat a gastric aspirate. And on repeat testing, we don't send a gene expert, we do a smear and we do a culture. Okay, so we have to document that the culture is negative. The reason behind it is we all know that CBNAT is a DNA test. Okay, it picks up the DNA, amplifies it, and it gives us a report. So even if a dead bacillus, few amount of dead bacilli are present in the sputum sample, the test is going to amplify it and it will give a positive result. okay, at the end of 2 months or at the end of 6 months, and therefore molecular tests are never used as a follow-up test. Follow-up test, if you want to see the sputum conversion, so initially it was positive and whether the child has now turned negative, only a smear and culture is done, because culture will only be positive if the bacteria multiply, and bacteria only if they are living they will multiply. A dead DNA won't multiply. Okay, similar for extrapulmonary. Extrapulmonary, what happens is most of the times we rely upon the clinical judgment, because suppose we have done a lymph node biopsy from the abdomen or even a cervical node, at the end of 2 months or 6 months, nothing is left. Everything undergoes resolution and we don't have a sample. So most of the time, what happens in a extrapulmonary TB is we rely upon a clinical judgment that the patient is the symptoms have gone away, the patient is gaining weight, he has taken drugs compliantly, and therefore we stop the treatment. Yes, if it was an abdominal kind of a TB or a pot spine, and I mean, initially the lesions were severe. Sometimes, the patients come with severe ileocecal involvement, contractions, nodes. We might do a screening ultrasound at the end of the therapy and take a call if, I mean, what is the amount of active disease still left behind.
So in reference to the pulmonary pleural effusion, one of the person wants to know if CBNet Ultra shows MTB trace and RIF intermediate in pleural tap. How do we interpret this and treat it?
So whenever we talk about any CBNet report, whether it is CBNet or CBNet Ultra, okay, so this we always tell whenever we get a report. Now there are certain labs which are accredited by the NTP or program. Like if you send it to a government or BMC hospital, the labs are accredited. In private, there are certain labs like Induja is there, SRL is there, Infexin is there. These 2-3 labs are accredited by the program. So when they give the report, they will give the report as MTB detected, okay, and the detection level, whether it is low, medium, high, or very low, right? So these 4 things you get in a CBNAT report or a gene expert report: high, medium, low, and very low. And in Ultra, we get an additional variant, which is trace, the last one. Okay. So this is very important because the whole interpretation of the resistance depends upon whether it is high, medium, low, or very low. So in case of a gene expert, I'm not talking about Ultra, gene expert, anything which is high, medium, low, and rifampicin resistance is present, we take it as a valid test and it is considered as a drug resistant disease and we start treatment accordingly. Now, if the gene expert flags MTB detected very low and rifampicin resistance detected, then we are in a soup. Okay, then we have to go back and take the history. We have to look into the factors which are known as epidemiological risk factors, or what is the pre-disease possibility that this could be a DRTB right from the first attempt. So what do you mean by that is, if the child was a defaulter, if the child was a lost to follow-up child, there is a confirmed case of DRTB in the close household. For example, mother is on treatment, father is on treatment, some death has happened, then this becomes a high risk patient. So if such a factor is present, then again very low is taken as positive and you start treatment if rifampicin is resistance. Now, if these factors are not present and it shows very low, are resistance detected, the protocol says you repeat the test one more time because you want to be doubly sure that this is a resistant organism. Okay, the whole reason being the therapy is for a longer duration, almost double the duration. There are more number of drugs involved and more side effects, so that we want to be doubly sure. Now coming to the indeterminate part. Okay, so if the test says rifampicin MTB detected low, rifampicin resistance indeterminate. Now indeterminate, to tell you in simple words, that means the machine was not able, or the test was not able to generate or pick up what is the resistance pattern. Okay, it happens, it is like a machine error kind of a thing. You repeat the sample. So indeterminate does not say anything. Okay, the machine was not able to tell that whether ये resistance है या sensitive है, तो आप repeat करिए test. That is a simple conclusion. Indeterminate के लिए we have to repeat the test.
Yeah, that almost cover up the entire thing for the same. Thanks, sir. Another case, like the child is case of TBM, has started on first line of AKT. So this is related to drug-induced liver injury. He developed hepatitis. He was shifted to second line of drugs. Liver function test normalized. The clinician is suspecting pyrazinamide-induced hepatitis. So what should be the next line of action for the child?
So the thing is, if it was a drug-induced hepatitis, we have a protocol, right? So we know in the first line anti-TB drugs, isoniazid, rifampicin, pyrazinamide are the drugs which are known to cause drug-induced liver injury. And because this is a case of CNS TB, we stop these drugs and we put the child on 2 alternative drugs, which is a streptomycin and a quinolone, streptomycin, quinolone, and ethambutol. Now, once the hepatitis comes down, we start introducing drugs one by one. Okay, So we don't suspect pyrazinamide. We have to prove that pyrazinamide is a culprit. Okay, and how do we do that is we first introduce rifampicin. After once liver injury happens, we stop the three drugs for a period of 1 week. After 1 week, we repeat an LFT. We see if the LFTs have normalized. We introduce rifampicin first, get an LFT after 3 days. If the LFTs is still normal, introduce isoniazid. Again, get an LFT after 3 days and introduce pyrazinamide. Okay, and again after introducing pyrazinamide, get an LFT after 3 days. So that is how we do step by step. Now at any particular step after introduction, if the LFTs go up, which most commonly happens with pyrazinamide because pyrazinamide is a culprit. Okay, but it can happen with rifampicin also, it can happen with isoniazid also. Commonly it happens with PZA. Then we prove that this is the offending drug because after second time introduction into the patient, the LFTs have gone up. Then we omit that drug and we replace it with another drug, which is mostly a quinolone. Otherwise, just starting empirical second line, it is not indicated. We again go back to the first line. And this happens, if I want to give a rough figure, it is hardly 15 to 20% of patients. Okay, 80% will still tolerate pyrazinamide.
So it's not as uncommon as we think, but then this is the flow chart how you should go about it. So
Yes,
systemically, you can just get the perfect idea about it.
yes.
Another very interesting question has come up, sir. It's a neonatal tuberculosis, which is actually quite commonly we see. The mother is already on the prophylactic treatment for tuberculosis, and she delivered in between the treatment. What should be the TB workup for the newborn, and is it necessary or not?
So if the mother is on prophylaxis, which means mother does not have active disease, okay, that means nothing to be done. Then nothing we have to do for the infant or the newborn. Sorry. If the mother is having active TB anywhere, during pregnancy, just before conception happened or during the delivery, then we have to investigate the newborn because the mother was having active disease during pregnancy, pulmonary or extrapulmonary. Then we do, chest X-ray, USG abdomen. If the X-ray is abnormal, we do a gastric aspirate. We rule out active disease in the newborn, and then the protocol follows. If there is no active disease, we also have to give prophylaxis to the newborn because mother was carrying active disease during the time of pregnancy. But mother is just on prophylaxis. That means we assume or we have to look into the fact that active disease in the mother has been ruled out and prophylaxis has been started. Then we need to do nothing for the infant or the newborn.
So even if the mother completes the treatment before giving birth, she had active tuberculosis.
Yes,
She has
yes,
completed the treatment during pregnancy, and then she delivers maybe say after a month. Then
yes,
still we should follow the prophylaxis in newborn.
yes, because she has completed treatment a month or maybe 2 months before, but for the
Yeah,
another 6 to 7 months she was still carrying the disease, and we
right.
didn't know what was the disease level, or you can say the bacterial load when she became pregnant, right? So when pregnancy
Right.
happens, the first sign comes, something around 8 to 12 weeks of amenorrhea, right? So it almost 2 months have gone when the mother first picks up that she's pregnant, right? So by that time, we don't know whether it has crossed or not. So even if the mother completes therapy just before giving birth to the child, and but she was on treatment for active TB, we have to investigate the newborn.
So there is one more question about the Mantoux positive test, which is very this thing. If the child is having severe acute malnutrition and
Yeah.
is Mantoux positive, should ATD should be started or not?
So we didn't address the question of Mantu. Okay, we remained
Yeah.
that we just spoke about active TB. We didn't talk about TBI or TB infection. So when we talk about TB infection, the skin test, the tuberculosis skin test, or popularly which is known as Mantu test, and the IGRA, okay, interferon levels in the blood, these are the two tests which picks up TB infection. Okay, so whenever if they are ordered, first of all, we should never order this test when we are suspecting active TB in a patient, and when we want to diagnose active TB, these tests are out of all the protocols. Okay, so if you have a patient coming up with 1 month of symptoms, you are suspecting abdomen TB or whatever, CNS TB, don't do a Mantu test because it only tells us that the person is exposed to TB, okay, which can be, 10 years before. Mantu can come positive because the child was BCG vaccinated. So there are n number of reasons why a Mantu test comes positive. It will only tell that the person or the child has been exposed to the tuberculous antigen. It will not tell you whether right now the patient is having active disease or not. So this is the first thing. Never order a Mantu or a IGRA for diagnosing active TB. When we want to diagnose TB infection, yes, we order a Mantu test or IGRA test. Now the preferred one is IGRA. The only reason being the Mantu, the standardized Mantu solution which used to be available, is out of the market since the last 4 to 5 years pre-COVID. I mean, it's not available anywhere in the world. Okay, and whatever we are getting is all the non-standardized solutions, so we don't know actually what results we are getting. It could be either false positive or false negative also. So if you want to order, IGRA is a better option that way, because standardized antigens are available. The second advantage of IGRA is it is very specific for MTB. Like we just said, BCG strain, what we use in BCG vaccine is a Mycobacterium bovis strain, but Mantu or skin test would come positive even if the child is BCG vaccinated, because the antigens which are used in Mantu test are the non-specific mycobacterial antigens which are common to the whole mycobacterial genus. In IGRA, the antigens which are used are specific for MTB. Okay, so if IGRA is positive, we know that the child or the person is exposed to MTB infection. Now, coming to the question where in a SAM patient, if again Mantu is positive, should we treat? Now, first of all, because if we go back to our immunology days or microbiology days, we all know Mantu is a delayed type of hypersensitivity, type 4. Now, SAM patients are known to be immunocompromised. Okay, so there is a more likely chance a SAM patient, even if having active disease, comes out to be Mantu negative. Okay, but if the SAM patient comes out to be Mantu positive, again the interpretation is same. If the child has been exposed, we don't know whether the child is having active disease or not. So, in a SAM patient or SAM severe acute malnutrition or even a moderate acute malnutrition, the protocol says all the patients have to undergo a symptom screen in detail, because TB is high on the list if the patient is SAM, and all the patients should get at least a chest X-ray done, because most of the times the nodes are sitting and nodes may not give rise to significant symptoms. The mediastinal nodes, they will just give rise to mild fever which can be missed or something like that. So all SAM patients undergo a symptom screening for TB and they undergo a chest X-ray. If anything is found on that, then we plan the investigations accordingly.
So what will be the absolute indication for doing Mantoux test?
Absolute indication is, so suppose now what the protocol, I mean the national protocol says is, because now they are recommended prophylaxis to be given to all the contacts of the pulmonary TB patients. Suppose we have a pulmonary TB open case in the house, whether it is DS or DR, all the household contacts have to be screened for symptoms of active TB. If there is no active TB, then we offer TB preventive therapy to all the contacts. Now, while offering this TB preventive therapy, a child up to 5 years of age, after ruling out active TB, we directly start prophylaxis. However, for children above 5 years of age and in adults, because now they are advocating preventive therapy for adults also. So, children above 5 years and in adults, they say that it is better if you do a test for TB infection, which is the place where you can do a Mantu test to diagnose whether the patient is exposed, or you can do an IGRA test. And if it is positive, and even if it's positive or negative, the program says you give prophylaxis. So it is just a formality that you are documenting that the patient is exposed to TB infection, and then you're starting prophylaxis. One more reason behind this is we can imagine we are giving prophylaxis to a person who is totally healthy. He does not have any signs and symptoms. He has just been exposed to a household contact probably. And especially when you go in the older age group, that is adolescents and adults, people are very resistant. मेरे को कुछ symptoms नहीं है, why should I take this 6 months of prophylaxis? So if a Mantu test flags positive or a IGRA flags positive, we are in a better way to objectively show the patient and counsel him, look, you have been exposed to the infection, so it is better you take it. Okay, like prophylactic therapy is not 100%, what you can say, it is not 100% effective, but yes, if taken properly, if at least you take 80% of the recommended doses, there is a 90% chance that your infection will not turn into active disease. So that it helps there to counsel the patients to take prophylaxis. Otherwise the protocol is very strict. If you don't have facilities, sometimes you are practicing in a district place where you don't have a Mantu solution or you don't have IGRA test, you just start prophylaxis after ruling out active TB. You counsel the parent and start.
The duration of the adult prophylaxis also will remain the same, sir?
Yes, 6 months.
Yeah.
So we have two options now in drug sensitive TB. If we want to give isoniazid alone, that is given daily for 6 months. Now the program has also come up with a combination tablet of isoniazid and rifampicin. Okay, the advantage of this tablet is it is taken only once a week, and it is for 3 months. So the compliance is much better with this, because only on a Sunday we ask the patient, Sunday morning नाश्ते के पहले tablet ले लो, and it is done. You take it for 12 Sundays and your prophylaxis is done. So this can be given instead of 6 months of isoniazid. Okay, where rifampicin group of drugs is not contraindicated. The only thing is this therapy is given only to children 2 years and above. Less than 2 years, rifampicin is not yet validated in children. So 2 years and above in adults, you can give this 3 months of therapy, weekly therapy.
So How come there is no prophylaxis recommended for contacts of drug-resistant cases?
No, it is recommended. It is recommended.
Okay,
It is there in the
okay.
program since 21. So if we have an index case who is a pure MDR case, that is H&R resistance, and we have a confirmed report that he or that index case is not resistant to quinolones or any other drug, okay, then the contacts of all such patients also can be given 6 months of levofloxacillin as a prophylaxis therapy. Again, the same, you rule out active TB in the contacts. If there is no active TB, you put the child on 6 months of levoflox. So
Okay.
it
So
is
what will
very.
be the brand name of INH and rifampicin drug as you suggested to give once in
I
a
don't know the brand name because
yeah.
the combination is available through the program. So it's a HR combination which is there.
So does the negative IGRA test have a good NPV?
Negative IGRA test have a
Good NPV? I think he meant to say good predictive value.
predictive
Negative
value.
predictive value. Yeah.
Negative predictive value.
Yeah.
Yes. As far as ruling out infection is concerned, yes, it has a good negative predictive value.
So when just going towards as you said, drug resistant cases, when we can suspect in the cases like, the patient is non-responder or can be a drug resistant case, what will be the red flag signs we should look forward, sir?
Yeah. So like we said, we discussed just a few minutes back, there are certain situations where we would upfront suspect a DRTB. Like for example, the child was a case of DSTB and he has defaulted on treatment. The compliance to medications was not good. The child is a relapse case or recurrent case. Few years back he was treated and he is again come back with active TB. That is one category. Second, if we have a confirmed case into the household who is on treatment for DRTB, it becomes a very high suspicion for DR because children mostly acquire the disease from the adults or close contacts. Third, if there was a death in the family because of TB. Now, as by and large, if a drug sensitive TB is picked up on time and it is being treated properly, the patient is taking the drugs properly, generally they don't die. Okay, because it is a simpler disease to treat. But if the patient has died and we don't have the treatment details of the index case, probably the death has happened either because there were some other comorbids or the patient was suffering from an undiagnosed or untreated DRTB. So all and HIV positive child. Okay, if it's an HIV positive immunocompromised child, we suspect DRTB. The suspicion of DRTB is a little higher. Now the second part is if what you can say the child was on treatment for DHTB. Okay, matlab, for example, a pulmonary or extra pulmonary, we had a microbiologically proven report that the child is rifampicin sensitive. We started on treatment for DHTB. At the end of 1 month or maybe 2 months, the child is not responding. Okay, that yes, that is one of the factors where we start suspecting to be it to be a DRTB. But before we directly jump on DRTB, there is certain set of questions or certain background homework. What we need to do is first and foremost is the child taking the drugs properly. Okay, because we have seen nowadays in the last 1.5 year we have seen at least 6 to 7 kids coming with low therapeutic levels of INH and rifampicin. We have done their therapeutic levels. I mean, multiple times their gene export and culture was done because they were not responding, and finally at 6 or 8 months of therapy they were referred to us with 2 or 3 reports of cultures, everything showing drug sensitive, and the child is not responding. Then we happen to do the drug levels, and the drug levels were low of either only rifampicin or sometimes rifampicin INH both. And the fun part is when we went into the details of these patients, 90% of them were not taking the drugs properly. Okay, the simplest error being if we see if we see the fixed drug combinations which are available through the program, we have one pediatric tablet which contains HRZ and one ethambutol tablet. So depending upon the weight bands, we tell 3P and 3E. That is three of pediatric tablets and three of ethambutol. There were two of the patients, those 3P tablets, the mother was giving those 3P as one in the morning, one in the afternoon, one in the night. Okay, and if we divide that, the therapeutic levels are not reached. So we just what we did was club all the tablets at one particular point of time. So as simple as that. Then we had adolescent girls who were not taking the tablets. We had one girl who we did levels 3 times. We confirmed with the parents at least 100 times is the child taking the tablets properly, and we did the level 3 times. Every time after doing everything, the levels were still coming low. Now we were about to start the patient on a DRTB treatment, and then one fine day suddenly the father comes up to the OPD crying and he says, we are very sorry, but now we have come to know my daughter is not taking the medications. 15-year-old girl. And then we say, why, what went wrong? You just told us we were giving the tablets. No, what we used to do was we used to give for the initial 2 days. तीसरे दिन से लड़की बोलती थी मैं मेरे रूम में जाके लेती हूँ, एंड रूम में जाके वो खिड़की से बाहर फेंकती थी. Then when we sat across the girl and spoke to the girl was, I mean, 15-year-old girl. So we asked, why did you do this? She's like, no, I didn't know this is so much. I mean, this TB is so bad and it's so important. I was happy that because of the disease, I was losing weight and I was, looking good and slim. Okay, so these are the adolescent issues. Okay, when I started taking tablets, I started gaining weight. I didn't want to gain weight. Okay, so we had to put her through a psychiatric counseling, get her concepts out. So these are the things, when the patient is not responding, the most important reason for not responding is whether the patient or the child is taking the drug sensitive treatment properly, and if everything is in place. Second most important is if it was a clinical diagnosis to start with, especially in cases like abdominal TB or a joint TB, knee effusion or a hip effusion, where we rely only upon the clinical acumen. We have to go back and see whether our initial diagnosis was right to start with. Okay, we have had monoarticular patients started on AKT, and then we come to us, we rework up again, and they are coming up ANA positive on immunofluorescence, and they are, the complete diagnosis changes. Okay, then comorbids. If the TB patient is having SAM, having vitamin D deficiency, having anemia, we have to treat it simultaneously. We have to build up the nutrition, otherwise the patient is not going to respond. So after going through all the exercise, we have ticked all the boxes that this is in place. Then we suspect, yes, the patient is still not responding, this could be a drug resistant TB.
Sir, for the adherence and compliance, if the patient is compliant and adherent to the treatment, but how you will judge the response with pulmonary tuberculosis and CNS tuberculosis besides clinical? Do we repeat chest X-ray? How and when? And for the CNS tuberculosis, CSF or CT examination, how frequently to repeat, sir?
Like I said, we have to repeat the test, but the test which is repeated is the sample. Like for example, in pulmonary, we repeat the sputum at 2 months and 6 months. And CNS, we would repeat if the CNS initial picture was meningitis, that is on our routine, or if the gene expert was positive, we would repeat a CSF at 2 months and 6 months. And the test what we send is a culture. We just discussed it. There is no point in repeating radiology. Like we have learned in the basics. Suppose the chest X-ray was showing a cavity or maybe a consolidation. At the end of 2 months, it may not have been totally cleared. It may have been reduced or it may not have been totally cleared. If it is not totally cleared, but if the patient is absolutely asymptomatic, the patient has gained 3-4 kgs of weight, then the patient is responding, nothing to be done. Okay, but what happens most of the times, if the X-ray is ordered and we see some funny shadow, then our brain starts working, probably ये क्या हो गया है, respond नहीं कर रहा है. And going one step ahead, nowadays we have come up with the concept of IRIS, or immune inflammatory reconstitution syndrome, where you start treatment. So this came into picture with HIV treatment. We picked it up first during the treatment of HIV. Now it is a very well-known fact with TB also. So initially there would be a cavity or a consolidation. You repeat an X-ray after a month or something like that, the cavity won't be seen, and a one lobe consolidation may have turned into a two lobe consolidation. But if you correlate clinically, the patient is doing absolutely well. Okay, there are no symptoms, the patient has gained weight. So then what do we do? Nothing. So that is why we don't repeat radiology, whether it is a CT scan or whether it is a chest X-ray. We only repeat the tests. Yes, when do we want to repeat a chest X-ray or CSF? If the patient develops some additional symptoms, right at the end of, so 1 month or 4 weeks is the waiting period to see how significant is the response. By the end of 1 month, the fever and everything should have significantly gone down or vanished. Okay, and the patient should have started gaining weight. If this is not happening at the end of 4 weeks, the patient is not showing appreciable response, matlab not gaining weight, fever is still persistent, or if the child is worsening at the end of 1 month or any time earlier, that is a time, yes, you would want to repeat a radiology, either a CT brain or a chest X-ray. Again, in CNS, it is not a protocol that you keep on doing CTs every 2 weeks, I mean 2 months or 6 months. Okay, if at all you want to do, that is also what we do is, if the patient had presented to us in stage 2 or 3 disease, TBM I'm talking about, at the presentation, then at the end of 1 year we would like to document an MRI. Okay, because MRI is a more sensitive investigation to see if there is any residual disease left behind. Okay, and what are the sequelae which are there, because in stage 2 and stage 3 disease, there is lot amount of inflammation and vasculitis. So most of the times the child is going to be left behind with some amount of neurological sequelae. So it helps us prognosticating the child. We can explain to the parents, look, the child is going to have this neurodeficit, probably hemiparesis, or the vision is going to get compromised, hearing is going to get compromised, but not per se, we don't keep on repeating the scans.
What should be the diagnostic and therapeutic approach to isolated ophthalmic tuberculosis like Flickton uveitis?
So again, there is a what you can say divided opinion. So if there is just a flictin, nothing at all, so it is like an immunological response. So there is a divided opinion. Some people say if there is only flictin, you go to a trained ophthalmologist, get the complete evaluation done, look at the retina, look at the vitreous, look at, sometimes there could be vitreous, precipitates, or there could be keratic precipitates on the posterior, I mean posterior synechiae formation at the back of the lens. So all this has to be looked into detail. So in addition to flictal conjunctivitis, if any of the other features are also there in the eye, okay, we don't take a chance, okay, because there is no way we can have a microbiological diagnosis from the eye. We cannot put a needle into the eye and take out the sample. In addition to flictinular conjunctivitis or flictin, if there are any other features seen in the eye, we start the treatment for drug sensitive TB. But if it is just a flictin and nothing else, okay, and also we do a chest X-ray for screening, because sometimes the primary may be picked up into the lung, because primary is always in the lung. Apart from that, if there are no other findings in the eye, just a flictin, just a small nodule, we don't do anything, we just keep the child under follow-up.
So with certain medications and treatment, it is recommended to have a yearly tuberculosis screening. So what test would you recommend for the same?
So we are talking about the immunocompromised patients, right?
Yes, sir.
Yeah, so again the same thing. So you do a symptom screening. In fact, not yearly, it has to be done every 6 months. You screen for symptoms of TB and you do a chest X-ray every 6 months. And if there are symptoms pertaining to any specific organ, then you plan the investigations accordingly. What you want to do, you want to do a CT, I mean UAG abdomen or something like that. But otherwise, symptom screen and chest X-ray.
So one of the person wants to know, if you have a drug-resistant tuberculosis, how you will decide the regime? Short duration, long duration, how the therapy should be guided?
So there are inclusion and exclusion criteria. Like we have a shorter regimen which runs for 9 to 12 months, 9 to 11 months, and we have a longer regimen which goes on for 18 to 20 months. Now, if the patient is MDR TB without any additional resistance to quinolones, that is, it is a pure MDR TB, it has a very limited disease. What do we mean by limited disease is, if it is a pulmonary TB, only one of the lobes is involved, okay, or only lymph nodes are present without any airway compression, there is no cavity, there is no bilateral disease on chest X-ray, okay, that is a limited disease as far as pulmonary is concerned. As far as extra pulmonary is concerned, in pediatrics, any lymph node anywhere into the body, or a mediastinal lymph node which is not causing an airway compromise or airway compression, only these two are considered as minimal extrapulmonary. Rest everything, whether it is abdominal, CNS, kidney, everything is considered as a severe extrapulmonary. So if it is a minimal pulmonary, minimal extrapulmonary, a patient is having MDR, no additional resistance to quinolones, and the patient has not taken the drugs which we are going to use in the shorter regimen, the new drugs, that is BDQ, levofloxacin, clofazimine, and ethionamide. If the patient has not taken these drugs for more than a period of 1 month, these are the inclusion criteria where we would be starting the patient on a shorter course of therapy. Anything which is there which does not fit into this, the patient goes on a longer therapy.
So is there any test for TB based on CD4 and CD8 ratio? Some labs are doing test TB sure.
So that
What
is
is it about?
this is an test which is an advanced IGRA, I would say. So it is a fourth generation IGRA which they are doing, but still the test is not validated. So what they are doing is they are studying the specific CD8 and CD4 positive T lymphocytes which are activated after coming in contact with an MTB active antigen. Okay, so these are tests which are available in the market, but we don't recommend it right now because, again, as I said, there are no studies which are validating this test, and even the WHO has not yet validated these kind of blood tests to diagnose active TB disease. Like it is,
So,
it is
so
in the
if,
same way,
yeah,
it is in the same way, as we have pyro sequencing and next generation sequencing for TB.
gene
It is
sequencing,
yeah, it is available very freely. Most of the labs are doing, but when we
not
order the test and when we get the reports, whether it is correlating with the patient, we don't know. Okay, so even the WHO says we have to develop our country database. Okay, so suppose if X number of mutations are found, whether they are actually working in that patient, and we are developing that database with the NIRT, which is their National Institute of Research in TB, which is there at Chennai. They are generating India's database. They are collecting samples. So what they are doing is, whatever samples which are run by pyro sequencing and the mutations are picked up, they are simultaneously doing a phenotypic DST for all those drugs. Okay, they are correlating whether the molecular is matching with the phenotypic DST, and the clinical manifestations in the patient. So then once we have our own library of all those things, because mutations, if you see, there are around 15 or 16,000 mutations which are there in the WHO TB atlas for anti-TB drugs. So we don't know in which country or which part that mutation is working. So again, pyrosequencing has to be ordered very, judiciously. Not because it is available, marketing happens, labs will come and tell you it is a very good test, send the sample, you will get a result within say 1 week and you get all the drugs, but you don't know what is actually going wrong in the patient.
So you have to use it judiciously and in context to 1:1 patient's
Yes.
relation.
Yes.
So if every child who comes to us and diagnosed to have tuberculosis, should we do drug susceptibility in every kid? And sometimes the lab, the financial burden is an important thing. So where such patients can go, then to have the
Yeah.
things in a proper way.
So now the protocol is whenever we are sending any sample, whether it is pulmonary or extrapulmonary, we have to send 2 samples. Okay, preferably. But preferably, why I say, because extrapulmonary sometimes we may not be able to get that much sample, especially when it is a biopsy sample. So when we send 2 samples, the lab puts one for CBNAT or gene expert, and once it is positive, so that is what happens in the national program. Okay, once the sample is positive on CBNAT, the another sample is immediately taken up for culture. Now, this is as far as adults are concerned. Now, we are a privileged population, that is pediatrics. So, there are 3 high risk groups which the program labels. One is pediatric population, one is extrapulmonary TB, and one is HIV positive people. So, in these 3 categories, even if the CBNAT comes out to be negative, the second sample is reflexively taken for culture. Okay, so if we route our samples through the program, we don't have to specifically tell the laboratory that do a culture. They will do the culture, and they will, we have to just trace the reports. But if we are sending to a private lab, for example, say Infexing or SRL or Induja, whatever, there we'll have to mention that we want to do a culture, because in private labs, the costing is different for different tests, right? Gene export or CBNAT has different amount which the patient has to pay. The culture has a different amount which the patient has to pay. And if the culture comes positive, then the DST, if we want to DST, then the patient has to pay additional amount. So that is why if we are sending it to a private lab, we have to tell specifically we want a gene export and culture both. Now, as far as doing DST is concerned, if the organism which we have picked up is a rifampicin sensitive organism, okay, that is R sensitive, the first DST which is done is for isoniazid, because in India now we are reporting around 20 to 24% of isoniazid monoresistant TB patients. These are adult figures. We don't have figures too much in exact figures in pediatrics, but yes, we are looking at around 25% cases of H monoresistant TB, and therefore even if the gene expert picks up rifampicin sensitive, an LPA is done, or if the LPA cannot be done on the culture, the LPA is done and a sensitivity to INH is picked up. Now, if the INH is sensitive, the story ends then and there, because R is sensitive, H is sensitive. So it is a drug sensitive TB. Suppose if the isoniazid resistance is picked up on the DST, then this becomes a case of isoniazid monoresistant TB. There is a different regimen for an isoniazid monoresistant TB. And if we pick up this, then additionally, DST is done for levofloxacin, moxifloxacin, and your pyrazinamide. This is because these are the drugs which we would be using to treat isoniazid monoresistant TB. As far as drug resistance is concerned, so if the first sample flags rifampicin resistance, that is R resistance is there, then invariably on the LPA or on the culture, we do both the DSTs. We do DST for H, that is isoniazid. We do it for quinolones, that is levoflox, moxiflox. We do it for injectables. We do it for linezolid and clofazimine. So that is the protocol which is followed. So yes, DST has to be sent. I mean, the culture has to be sent for every patient. Depending upon what is the primary report, the lab will decide what DSTs have to be done.
The quick word on Nikshay, if we can just, as you correctly said, if we go through the government setup, they don't have to go for all this procedure, financial
Yes.
burdens. It will automatically direct it for their sake.
Yes.
So
Yes. So Nikshay is basically, it is a government portal which helps us in all the TB related activities. Okay. So as far as sample sending is concerned, you can contact the district TB officer or DTO which is there. For example, Mumbai is divided into 26 wards. So every ward, or sometimes if the wards are small, 2 wards have a DTO or a district TB officer. Every one of us should have the number of a district TB officer with us. Any problem with with a TB patient, be it related to sample sending or tracing of reports or availability of drugs, we can directly call the DTO and he will cater to it. Okay, so if we want to send a sample, the patient is not affording, if we want to route it to the program, just call up the DTO before collecting the sample. Look, we are planning this test, we want to send a sample to the program. The DTO will send his representative, either a senior treatment supervisor or a house visitor, and they will get the things done for you. Okay, that is as far as sample and the reports you can trace. Now Nikshay, what is there? That is it is a name for all the TB related activities. Okay, Nikshay means ni is no and Kshay means TB. So no TB. That is why it is being named as Nikshay. So what the government of India has done is there is a mobile app which is available. You can also access it on our laptops, but app is very user friendly. On that application, now it is the current version which is going on is Nikshay 2.0. They are coming up with Nikshay 3.0 also now. So every detail of the patient, once the patient is notified to the program, immediately the details of the patient come up on the application or on the Nikshay portal. Okay, so right from the clinical features, how it was diagnosed, only the what you can say the cardinal features, like for example fever and weight loss or fever and seizure, something like that. Then what tests were positive, the reports of CBNAT, the reports of culture, what is the date of starting regimen. Okay, and if the regimen has been changed, that also pops up. So that becomes a very useful, handy, you can say data source for us, especially in places like JJ where we sit into the OPDs. Our TB OPD, we are seeing around 40 patients every OPD, and many of the times patients forget their files at home or files are lost, something like that, and we want to know what was the resistance pattern 3 months back. We have to just put the Nikshay number. So every patient who is notified or the sample goes to the program gets a unique ID. Like all of us have an Aadhaar ID, like the TB patients have a Nikshay ID. That ID remains with the patient throughout the course of treatment. So we just have to put the Nikshay ID into the application or into the site, and you will get the entire information details of the patient. And then there is also a toll-free number of Nikshay where the patient or even the doctor, but the patient can call up and talk about his grievances. Suppose the patient is not getting drugs, सैटरडे संडे आ रहा है, टीबी ऑफिस बंद है, कुछ भी है, they can just call up the hotline number and the problem will be solved.
I think there is too much of a classy test match techniques everybody is getting in T20 format because we have a limited time. And since almost, we can just go on and on because sir is a master and, there's so much vast to cover. So Dr. Rajesh sir, I will request you to please keep one more session. I think this much, now our attention span also maybe, started waning a bit because it's almost an hour. So I think maybe we can go
You
for
can take
50 over.
the
Yeah,
Arpita, you can take the 2-3
two,
questions
three
that have come
questions are
up now
left.
before we
Sure,
wind up.
sir. I'll just, quickly, sir, few more questions has come up because I think everybody wants to absorb every knowledge, we can get it from you in today's session. So, sir, what about pyridoxine availability at the OPD and similarly steroids for CNS tuberculosis?
So it is available. Pyridoxine is available as a Benadion tablet, 40 milligrams through the TB program. So
Yeah.
lesser strength is not available. So what we do in kids is we give half the tablet. So that serves the purpose. 20 milligram we can give. Suppose if that is not available, sometimes it may happen that it runs out of stock. Then we can give our multivitamin syrup, which we prescribe to our children. Just we should check that multivitamin syrup contains at least 10 to 20 milligrams of pyridoxine. That also serves the purpose. That is one thing. As far as steroids are concerned, so there is some question: do we give steroids for abdominal TB? No. Okay, there are specific indications for steroids. So CNS TB is one indication where definitely we would be giving steroids. Pericardial TB is another indication where we would be definitely giving steroids. Adrenal TB, yes. Ocular TB, okay, and miliary TB with significant amount of hypoxia. So if a miliary TB patient is requiring oxygenation, we do a blood gas and ABG, and there is significant hypoxia. These are the patients where we would be giving steroids upfront because there is lot amount of inflammation and we want to get down the inflammation. The duration is variable. For CNS TB, we give steroids in full dose for 4 to 6 weeks and then taper it over the next 2 weeks. So the total duration of steroids becomes around 6 to 8 weeks, and the dose is 2 milligram per kg morning dose what we give.
Sir, is Nikshay registration is compulsory for everyone, even for the private practice? And
Yes.
and we get ID number when the sample is sent or when you start the treatment?
No. So suppose if we suppose the patient is coming to us since a week, okay, we are working up the patient. At the end of 1 week, now we know that this is a TB patient. We have confirmed the diagnosis. Just enroll the patient on Nikshay and the ID will be generated. and that ID will be used, I mean, for further all references as related to that patient.
So I think we can call it as a wrap. That was very extensive knowledge given in a very concise and encapsulated form. Thanks a lot, sir, to give the sudden inputs, which were really, we were not about knowing about DR, tuberculosis, prophylactically in neonates. There's so many more zones to cover, but I think we will require you to have one more session. Please, I'll hand over to Dr. Rajesh, sir, for the...
Yeah, I think
Yeah,
thank
sir.
you, Sushant, for those absolutely crisp answers as usual.
Thank
And
you,
it
sir.
was very, very useful to revise our so many concepts about tuberculosis. As Arpita said, this session can go on and on and on, but I think at this time of the night, it's limited things
Yes.
that we can absorb. So we'll certainly have more of this series on the same topic because this is a very, very important topic. Thank you everyone for joining in. Thank
Thank
you, and please join for the remaining 3 parts of this same series. So tomorrow is hemato-oncology, Friday is neurology, and Saturday is antibiotics in office practice. So request everyone to join in for all of that. And once again, friends, it is IAP elections are on. So request each and every one of you to vote for IAP elections. We want more and more of you to participate in IAP as much as possible and
Mumbai
request
likes
you to put in your zonal groups that you have voted. Because many of you have already voted and we note that. Dr. Noshir Dalal, Dr. Sushma Save, Dr. Sushant, of course, and so many others have already voted and put it in the groups. But others, please vote and put it in the groups that you have voted. And please join for tomorrow's session again. See you again tomorrow. Sushant, you want to say something?
No, that's just vote. We have to do that.
Yeah.
Yeah.
Okay.
Thank you.
Anybody else? Nehal, Amruta, you want to say something?
No, sir. No, sir. Thank you, Sushant. It was an
थैंक
amazing.
यू
Thank you.
सुशांत के साथ पर्सनल सेशंस करना पड़ेगा टू कंटिन्यू मोर
So we also want to gain more knowledge.
He's very active on the
Sushant?
TB group anyways. He keeps on answering a lot of queries.
Yeah, everybody is
Yeah.
there in that.
Yes.
Yeah.
Yeah. Bye bye.
Thank you
थैंक यू
once again,
सुशांत थैंक
everyone,
यू
for
एवरीबॉडी
joining
Thank you,
in.
everyone.
Thank you.
Thank you.
Yeah,
Thank you.
yeah. Good night.
If anybody has any problem with the
They
voting
want to
message
know
or
the
link,
tomorrow's link also. Is it the same link or they will have to go
no,
for the
it is
another
a new link. It is posted in all the zones.
zonal, na?
So it
Yeah.
will be
It will be
posted
sent on
again
your zone.
tomorrow.
Yeah.
Yeah.
Sure. Good night, sir. Good night, everyone.
Good night.